Hey, Stephanie, I'm just going to try to share my screen. Can you tell me if you can see it and if it works?
Yes, I can see it. talk.
Stephanie, do you want me to just start or?
Let's just wait a couple more minutes.
Okay, sure.
Thanks.
Welcome to Grand Rounds. The distant but not old Grand Rounds. Presenting in this fashion is not easy for the presenter, nor is it easy for the viewer at times and the participator, but this is the format we have. And so I'd like to welcome Dr. Michael Luong from the Division of Cardiology to give an update on geriatric heart failure. And as you can see by the title, it's not all old news. Dr. Luong.
Perfect. Thank you so much for that, Dr. Casson. So yeah, I'll start with my part of the talk, and then Dr. Benny Lau will then talk a little bit about the cardiac rehab portion as well as it relates to the geriatric population. Thank you again for having me speak today. So we'll just get started here, and hopefully we can all get a little bit of insight today with this special population that we deal with all the time. I don't have any relevant disclosures for this presentation. So I don't have to explain to everybody who's in the presentation here, but we all know that the life expectancy of everybody is increasing. But what's really unfortunate is that the healthy life years may very well be decreasing because of all the life-saving technology that we have. People are living longer, but not necessarily living better or happier lives. In fact, one of the largest growing segments of the population are those over 85, and those patients or those people, that population is expected to double between the years of 2010 to 2050. So we really should have a better understanding of how to best treat these patients because we'll be one of them soon. This is in Canada, and so even back about 5 years ago, the number of patients or number of people who are over 65 has increased compared to those who are less than 14. And as you can see, those curves are continuing to diverge based on those projections. And this is already true in a lot of places, such as in Japan. But it's funny, but if you step back and think a little bit about this, this is only going to become a bigger and bigger issue as we start to live longer lives. This is important because not only for heart failure, but in all cardiovascular disease, it really is a disease of aging, and really that's the biggest risk factor with heart disease as well. And as we get better in treating arrhythmias, with coronary disease, with valve disease, people are living longer. And in fact, there's a quote from this paper, but mainstream cardiology has really become de facto geriatric cardiology, but it still lacks a systematic approach that incorporates age-related complexities into clinical decision-making. We all know we all age differently, and we've all said this, that there's an 80-year-old, but she's a good 80-year-old, or there's this particular 74-year-old, and I'll let you all decide if this is a good 74-year-old or not. But everybody really needs to be taken and treated differently, taking into account their values and their preferences. I'm not going to pretend to be a geriatrician, and hopefully I don't butcher this, but it's hard to mention anything about geriatric cardiology or geriatric heart failure without some mention about frailty. There's different definitions in terms of frailty. There's more objective measures, more subjective measures as well. But what we know for sure is that patients who are frail, heart failure is more prevalent in those groups. What we also know is that frailty is associated with worse outcomes, especially in patients who are elderly with heart failure. We're going to just start with a case here. And so she's an 83-year-old lady who has heart failure. What can you do for this patient? And hopefully we can shed some light in the next 20 minutes or so about what we have as options. So she's 83, her EF is 35%. She still endorses a fairly good quality of life and is very independent with her ADLs and IADLs. She's on fairly appropriate medical therapy, as you can see there, but unfortunately she gets admitted to the hospital for a heart failure exacerbation. She's diuresed and now is able to walk a few blocks, which is her baseline before she needs to stop. And she says, I'm 83-year-old doc, that's pretty good, right? And I think the problem depends on how you answer this question, because I would argue that there's a lot of people who would agree and say that that is pretty good. But the question is whether or not we can do better for this 83-year-old lady. And so hopefully with the next 20 minutes or so, we will see that this is really not the end of the road, and there will be options for us in terms of better management. The problem is that after one hospitalization, patients' 1-year mortality rate is probably around 30%. But when we talk about our geriatric population, that risk increases by up to 10%, up to about 40 or even 43% when you're looking at males. The problem as well is that there's perceived stability in a lot of these patients, which is not necessarily the case when we look at big studies and overall populations. You would argue that this lady probably has class 2 symptoms. But what we know about NYHA class 2 patients is that their annual mortality rate is not insignificant. In fact, it is up to 20%. And up to 40% of those patients who die will die from sudden cardiac death. And so you may not have a precursor hospitalization or like even a doctor's visit to really maybe have an opportunity to adjust their medications, because you really need to identify these patients early so that you can treat them, get them on good medical therapy, because their next presentation to the hospital may very well be for a sudden cardiac event as opposed to with just worsening shortness of breath. This is obviously not true anymore, and current is certainly in quotations, but even up until a few years ago, with our best medical therapy, including with device therapy, as you can see, after about 5 years, the overall survival is only about 75% in patients with heart failure, and this is despite with good triple therapy. We're going to start by talking with all of these components of our triple therapy and just hopefully shed some light into the evidence that they have, especially in the elderly population. We all know from lots of different ACE inhibitor studies that ACE inhibitors are good in heart failure. In the population that we're dealing with a lot of the times, it's those over 80 years old. And what you can see here in the Swedish analysis is that those over 80, you can argue perhaps derive an even bigger benefit compared to their younger counterparts based on the overall mortality as well as the mortality and heart failure hospitalization, with a number needed to treat of just around 10. Perhaps even more important though in the elderly population is that not only do you want to try to prolong their life, but you also want to make them live longer, happier lives as well. And so in this study looking at ACE inhibition compared to placebo in patients with heart failure, on a 6-minute walk test, you can see that here that they can increase their walk distance by about 37 meters in 6 minutes, which is actually a very significant improvement compared to their baseline without any ACE inhibition. The next study that we'll talk about, which is probably the most commonly quoted heart failure study in the elderly population, which is the seniors trial looking at nebivolol versus placebo. As you can see here, the inclusion criteria was those over 70 and included patients with EF less than 35%, but also some patients actually with heart failure with preserved EF as well, based on their admission. What we see in this study is that compared to placebo, the nebivolol group decreased the primary outcome with a hazard ratio of 0.86. All-cause deaths was also decreased compared to placebo as well. And as you can see here, the curves start to diverge fairly early on as well at perhaps less than 6 months. And so even though the patients are a bit older, if they're decent 80, 85-year-old patients, I think it's quite possible that you can change their lifetime trajectory with just initiation of the nebivolol. When we talk about beta blockers, one of the biggest things we worry about is side effects. And I'm sure we've all heard about the different side effects that they may or may not have. What I wanted to highlight in this slide is that the seniors trial is by far the study that enrolled the oldest patients. But what I want to show is that the patients who were able to get to target dose in this trial was almost 70%, which is actually higher than a lot of other big heart failure studies. And so really, depending on the patients and how careful we are in terms of increasing their medications, I think that we can safely and reliably get these patients on good doses of medications to try to improve their overall quality of life and then also improve their overall mortality as well. The last of the triple therapy options is the mineralocorticoid receptor antagonist. And so this was really put on the map with the Emphasis HF trial with almost 3,000 patients. The average age in this study was 69 and enrolled patients with class 2 symptoms or EF less than 30%. What we see here is the allopurinol group certainly seemed to have a decreased risk of death from any cause, as well as decreased hospitalizations for heart failure. And again, as you can see, especially with the heart failure hospitalization, those curves seem to diverge fairly early on as well. When we look at the older population, and they did a sub-study analysis looking at those over or less than 65 and over and less than 75, as you can see here, that benefit seems to carry true for both of these groups. Studies with older patients are certainly going to have less numbers as you get older, which is always going to be a limiting factor. But with almost 700 patients in the over 75 group, it still seems to carry on a significant benefit compared to placebo. But what we have now, which is I think what's exciting with practicing in heart failure, is that there's all these newer treatments that we have. We'll try to touch base on each one of these and their role in the elderly population, starting with Ivabradine, which was put on the map with the SHIFT trial. And then obviously sacubitril/valsartan with the Paradigm trial. And then most recently with the SGLT2 inhibitor studies with DAPA-HF and then Emperor reduced as well. So what is their role in the geriatric population? So with Ivabradine, what we know that it was a positive study when you look at the primary endpoint. When you look at the over or less than 65 group, again, it seems to still work well compared to placebo. It does seem to cross a line of unity, but the trend is certainly positive from what I could see here. The difference in the Ivabradine trial compared to some of the other trials is that the individual endpoints with heart failure hospitalization and cardiovascular death was not both individually significant, whereas it was really driven by the heart failure hospitalization. When you look at the different quartiles of ages, what you can see in those over 69 years old, again, this is about 2,000 patients now. There was a 16% relative risk reduction of the combined primary endpoint, which in this case was cardiovascular death and heart failure hospitalization, again, with the curves diverging fairly early on as well. Not only do we want medications to decrease these harder endpoints, we also want to see if they improve in terms of their quality of life as well. And so in this quality of life analysis, what you can see is that with the Minnesota Living with Heart Failure questionnaire, whether you're looking at the physical dimension score or the emotional dimension score, there does seem to be an improvement in both within about 2 months' time, and that improvement seems to carry on for the duration of the 6-month study. So patients may be coming into the hospital less, but they also feel better, both physically and emotionally better, perhaps even as quickly as 1 or 2 months from drug initiation. In terms of the safety side effects that we have to worry about with Ivabradine, specifically in terms of the elderly population, there is a high risk of bradycardia, which is not surprising given the mechanism of action with Ivabradine. However, it does not seem to have a higher risk of higher degree AV block, and it also does not seem to have a higher risk of atrial fibrillation compared to the general population of patients who are on Ivabradine. In general, the authors concluded that the Ivabradine was a fairly well-tolerated medication, but if we want to be a little bit more cautious or careful, particularly if they are a little bit bradycardic to begin with, we can always start with a lower dose and up-titrate more gradually or more slowly, perhaps at 2.5 milligrams twice a day as opposed to the 5 milligram twice a day dosing. The next medication we'll talk about is sacubitril/valsartan, and obviously, as everybody here knows as well, this is a combination medication with an ARB with valsartan and then neprilysin inhibition with sacubitril. We have seen from SOLVED and CHARMED and multiple other ACE and ARB studies that RAS inhibition is certainly beneficial for heart failure patients with decreasing the hypertrophy, decreasing fibrosis, decreasing blood pressure. And so what the combination medication does, it also taps into the neprilysin inhibition and natriuretic peptide system. And so we've known from a lot of basic study trials that the natriuretic peptide system actually is beneficial in decreasing sympathetic tone as well, increasing diuresis, decreasing fibrosis and aldosterone as well. Sorry about that. And what we can see, though, is that with the Paradigm-HF trial, looking at these two medications combined into basically compared to placebo, is that there was a significant decrease in terms of cardiovascular death and heart failure hospitalization in both of those individual endpoints. The difference was improvement by about 30%. And when you see that a breakdown between the less than 65 and more than 65 and less than 75 and more than 75, you can see that the sacubitril/valsartan groups seem to carry through with improvements in both of those age cutoffs. When you look at the different quartiles of age again, in those over age 75, which is almost 1,600 patients, whether you're looking at heart failure, hospitalization, cardiovascular death, the combined of those two endpoints, or all-cause death, the sacubitril valsartan group does improve outcomes compared to enalapril alone in all across the whole spectrum. The side effect profile of this medication, though, is not surprising, where the sacubitril valsartan group certainly has more hypotension. However, when you look at the renal function, when you look at the potassium, whether or not they have more or less cough or angioedema, there really was not a significant difference compared to the enalapril group. And in fact, what we saw is that more patients dropped out of the study with enalapril compared to the sacubitril valsartan group, really suggesting that this medication is really fairly well tolerated. When you look at the patients who are over 75, the overall safety endpoints was actually not that different. And in fact, the overall renal dysfunction, hyperkalemia was probably a little bit less compared to the overall population, perhaps maybe because people are a little bit more careful with this group of patients as well. Lastly, we'll talk about the SGLT2 inhibitors, and this was really put on the map by initially the diabetic trials, but then more recently by DAPA-HF, and then also in a little bit later on, we'll talk about Emperor Reduce. But in DAPA-HF, we looked at dapagliflozin versus placebo in patients with an EF of less than 40%. In this study, in the primary endpoint, what you can see here is the hazard ratio is 0.74 of the primary endpoint, which is composite of death from cardiovascular causes, hospitalization for heart failure, or urgent visit requiring IV therapy for heart failure. Again, as you can see here, the curve started to diverge fairly on, and it seems to carry on true for the duration of the 24 months. When you look at the different age cutoffs, here you can see that in the group age greater than 65 group, you could even argue that the benefit derived is even more so than their younger counterpart. When we deal with our elderly populations, especially here where I practice at Mount St. Joseph's, a lot of our elderly people are quite frail with a very low body mass index. And so what you can see here is even those who have a lower body mass index of less than 30 compared to those greater than 30, both of those groups seem to do well in terms of tolerating as well as responding well to dapagliflozin. When you look at the different quartiles of ages, again, for this study, again, you can see that those who are over 75 seem to derive as much, if not an even bigger benefit compared to those of their younger counterpart. And you can see that here depicted in more curves. Again, not only do you want them to do well from hospitalizations, but you want to improve the quality of life as well. Another common questionnaire that we use in heart failure is the Kansas City Cardiomyopathy Questionnaire. So this is a 23-point questionnaire. And so you can see here in those over 75, their score improved by about 4 points or so compared to the placebo group. And so on a 23-point score, improvement by about 4 points is actually very significant. And this is just hot off the press with the recent presentation at the ESC Congress. This looked at EF less than 40% with empagliflozin compared to placebo. And what you can see here in the primary endpoint, again, is that the empagliflozin group does seem to improve outcomes compared to the placebo group. And again, the curves seem to diverge fairly early on as well, at perhaps less than 3 months. Looking at their subgroup analyses, you can see here that the less than 65 and more than 65 group both seem to have benefits. Again, looking at the body mass index at the very bottom there, you can see that even those who are less than 30 with the BMI do seem to do better compared to even those over BMI of 30. What's interesting with the Emperor Reduced trial is that there were more patients on ARNI or sacubitril valsartan compared to the initial DAPA-HF trial. Still not a lot, but about 20% of the population were on ARNI. And what you can see here is irrespective of yes or no, you can see that both of these groups did do well with empagliflozin. And so again, this makes the question of whether or not this is added therapy or how they work together, but at least this suggests that they both work effectively together, and whether or not there's a synergistic effect, I think it's a bit early to hypothesize. There are more general tract infections with the SGLT2 inhibitors, as you all know. But overall, some of the initial side effects that we had worried about with the diabetic trials did not seem to hold true with the Emperor Reduce as well as with DAPA-HF. And so hypoglycemia, lower limb amputation, bone fractures, renal issues, volume depletion, it did not seem to be significantly impacted with the SGLT2 inhibitor based on the two most recent heart failure studies. This is a very busy slide, not really meant to show or read through all of it, but to really just highlight that there are a lot of potential mechanisms for how this works, but nobody fully understands exactly how it seems to reduce so dramatically the heart failure hospitalizations and cardiovascular death. But certainly an area that I think we're going to understand a lot more of in the coming few years with all the research that's coming out. This is not necessarily a slide for geriatric heart failure, but just to show that in heart failure now, there's a lot of medications that we have access to, and it's really an exciting time because there's something that we can do for these patients. And so whether it's triple therapy, whether it's added on ARNI, whether you add Ivabradine, whether you add SGLT2 inhibitors, I wanted to highlight the very bottom two lines here. And so with overall mortality, if you use all these medications, there seems to be a relative risk reduction by almost 73%, with an absolute risk reduction of 26%, and the number needed to treat, which is very impressive, is just 4. And so I do think there is a role in trying to get these patients identified early, get them treated, get them referred to their appropriate specialist, whether it's the heart function clinic or not. But there are options for us to try to manage these patients, and they do well, and they do have a decreased risk of overall mortality even at 2 years' time. Before I hand it over to Dr. Lau, I just wanted to kind of say, geriatric cardiology is, it's a term, but really shared decision-making really is the biggest factor here, because there's no cookie cutter approach in terms of how we best manage these patients. Everybody's going to be a little bit different in terms of values and their preferences and what they want in terms of their future. But the biggest barrier, I think, to treatment is the perception of harm. And hopefully I've been able to shed some light that there really is, there may be harm, and we certainly need to be careful with this population, but there certainly is a lot to gain as well with medical therapy, even if they're doing reasonably well for an 83, 85-year-old lady or 83-year-old man. And so from my perspective, there are a lot of medications that we have for heart failure to reduce EF, and there are benefits in elderly patients. Mortality, morbidity are improved, but so is quality of life. The benefits are similar, if not even better, in some of the older patients compared to their younger counterparts. There are risks, of course, as with anything in elderly patients, and so slow upward titration of medications is often necessary, but a fear of adverse events is not an excuse not to use evidence-based therapies, and hopefully I've been able to share some evidence earlier. It's always going to be a challenge looking at patients over 80 and looking for evidence, because there's always going to be confounding factors with comorbidities and follow-up and other health issues. But really, at the end of the day, it's going to be a multidisciplinary approach that we're going to need to apply. And it's not just for medical therapy, but lifestyle changes involving family members, especially in this COVID area, is going to be very, very important. And so hopefully that's a nice segue for me to pass it on to Dr. Lau, so he can talk a little bit about the approach with cardiac rehab. So I'll stop sharing my screen now, and hopefully he can start sharing his.
Can everybody see my slide?
Yep, they look great,
Yeah.
Benny.
Okay, perfect. Yeah, so now that Dr. Luong has gone over heart failure management with, again, focus on pharmacotherapy, I'm going to talk about the other cornerstone treatments in patients with heart failure, and that's cardiac rehab. And again, with a special focus in those older population. So just quickly, in terms of disclosures, I've sat on the advisory board and consulting for several companies, but clearly what I'm talking today has nothing to do with medications. And so, as I mentioned earlier on, cardiac rehab is a cornerstone therapy in patients with heart failure. And so why is that? Well, this is the HF Action trial, and this is one of the landmark trials of cardiac rehab in heart failure. And it is the largest randomized controlled trial. And it was published in 2009, included over 2,000 patients with HFrEF, so reduced ejection fraction, randomized them to exercise training versus the usual care, and then followed up for a median of 30 months. And what they've shown was that when you adjusted for potential confounding factors, and the hazard ratio for all-cause mortality and hospitalization was 0.89 for those people who has undergone cardiac rehab, so about a 10% reduction. And then when you look at specifically in cardiovascular mortality and heart failure hospitalization, similarly, there was about a 15% reduction in people who has undergone cardiac rehab compared to those who haven't. Subsequently, there's been other randomized controlled trials done, not as big as the HF Action. And this was a systematic review that was published last year, which included 44 trials with a total of about 6,000 patients with heart failure. Again, primarily in heart failure with reduced ejection fraction and less so with HFpEF. And what they've shown is that at greater than 1 year follow-up, there was a 12% reduction in all-cause mortality. They didn't see a significant difference in mortality at less than 1 year follow-up. Potentially, it may be because the event rate is lower at a shorter follow-up, and therefore it didn't show statistical significance. But in any case, at greater than 1 year follow-up, there was a reduction in all-cause mortality, a 30% reduction in hospitalization. And if you look at hospitalization specifically related to heart failure, there was even a greater reduction, a 40% reduction. And what's been fairly consistent across the board in all the different trials was that there was an improvement in the health-related quality of life. And most of these studies, the way they measure quality of life was using the Minnesota Living with Heart Failure Questionnaire that Dr. Luong kind of mentioned earlier on. So we know that cardiac rehab benefits those with heart failure, but what about those with coronary artery disease? So this was a large observational study involving 36,000 patients that was done in the Netherlands, and followed these patients up for 4 years. And as with most observational studies, they did propensity score weighting to try and account for any confounding factors. And what they showed was that those patients who did undergo cardiac rehab, there was a 35% lower risk of mortality compared to those patients who did not undergo cardiac rehab. And these are patients who have undergone a revascularization procedure or a valve surgery. There has been randomized controlled trials done as well. Granted, they're not as big, obviously, as the observational study. And this was another systematic review done by the Cochrane Group, published in 2016, which included 63 randomized controlled trials for a total of about 15,000 patients who has had an MI or has undergone revascularization. And in these trials, they were randomized to either cardiac rehab or no exercise. And in the left, the figure on the left, you'll see that in terms of cardiovascular mortality, there was an overall reduction of about 25 to 30% with cardiac rehab. And in the figure on the right, in terms of hospitalization, there was about a 20% reduction. Now, what they didn't show was an improvement in all-cause mortality. There was no statistically significant difference in all-cause mortality. So this is the part which is a little bit different from the previous observational study. But it did show a reduction in cardiovascular mortality and hospitalization. And again, what was consistent across all the different trials was that it did show improvement in health-related quality of life. So we know that cardiac rehab benefits those with heart failure and coronary artery disease in all comers. But what about in the older population? Do they derive less benefit, more benefit? There hasn't been as many studies done in the older population. And in the previous studies that looked at all comers, they did include older patients of up to around age 80 or so. And in the HF Action trial, which I talked about, was a landmark trial in heart failure, they did about half of the patients were over age 60. But again, they weren't specifically looking at the older population. Now, there have been studies looking at that, and this is another observational study specifically looking at cardiac rehab in patients with coronary artery disease. And it was a large observational study as well, about 600,000 participants aged 65 and older. Now, whether you talk about, over age 65, is that actually considered, nowadays the geriatric population? That's up for debate. But in this study, about a third of the patients were over age 75. And what they've shown is that on the left, when they compared those who did not undergo cardiac rehab, so in red, versus those who did undergo cardiac rehab in blue, cardiac rehab did result in a reduction in total mortality, and absolute risk reduction of about 8 to 9%. What they also looked at in this study was comparing those who were quote-unquote high users of cardiac rehab, so patients who attended more sessions compared to those who attended less. And so in red are those who attended less than 25 sessions, and in blue are those who attended more than 25 sessions of cardiac rehab. And what they've shown was that those who were high users derived more benefit. But even those who attended less sessions still did better than those who did not attend cardiac rehab at all. So aside from mortality, there has been a number of other studies looking at the other domains, so quality of life, functional capacity, and I'm not going to go into all the details of each study, but it has been shown that in the older population, that cardiac rehab does improve their functional capacity and strength. It's been shown to improve their ability to live independently and to improve their mood symptoms and to reduce depression. This is a randomized controlled study looking at the different domains that contribute to quality of life. And so on the left is results at 3-month follow-up. So basically at the end of a 3-month intervention. And in the hash bar are those who has undergone cardiac rehab, and the white bars are those who have not. And you'll see that in most domains that there was an improvement in those who has undergone cardiac rehab. Now, what's interesting is that they also looked at 6-month follow-up. So basically 3 months after completion of the rehab program. And you'll see that there was a lot of the benefit that they gained at 3 months was lost by 6 months already, which reiterates that in this population, especially in the older patients, it is especially important that there's a way for them to maintain their exercise routine, that there's a way to help them continue with their physical activity. Otherwise, the benefit that they derive initially is quickly lost. So now that we've seen that there are studies looking at the benefits of cardiac rehab in the older population, how do we actually going about prescribing exercise? And so this is a significant, important consideration when we prescribe exercise in this population. And my geriatric colleagues can, talk about this much better than I can and more eloquently than I can. But essentially, this is a population that is quite diverse, and that people with this at the same chronological age can differ significantly in terms of their response to exercise, their functional capacity, their frailty, and their comorbidities. So when it comes to exercise prescription, it has to be individualized. But there are some general considerations when we prescribe exercise in the older patients. First of all, we do put more emphasis and also more time on warm up and cool down. And the reason is when it comes to warm up, we focus on flexibility and range of motion exercises to hopefully help reduce musculoskeletal injuries during their exercise. And in terms of the cool down, why they need a longer cool down is that older patients typically has a delayed baroreceptor response. And so the vasodilation that occurs during exercise, in the recovery period, that vasodilation is slower to reverse. And so they're more prone to hypotension during that time. And so we like to have a longer cool down for these patients. Also, we tend to start low when it comes to the intensity and the duration of the exercise, and then gradually progress over time. Again, it's very different for different patients. We certainly have older than 70s who come in and is able to go for 10 minutes on the Bruce protocol, and clearly that's a different scenario. But in general, we like to go low and then gradually progress, and we tend not to be very aggressive with the progression as well. And there is a certain, when it comes to recommendation, the minimum requirements that we would like patients to do when it comes to their exercise. But for a lot of these patients, they may not reach that minimum requirement, and that's okay, because we know that those who can do even a little bit do better than not doing anything at all. Another consideration is that as we get older, muscular strength decreases. So we do focus a lot on resistance training. And that has been shown to, by improving the muscular strength, improve their balance and reduce the risk of falls. And for those with sarcopenia, sometimes because they are so weak that our clinical exercise physiologists have to focus on strengthening the muscles before we can even consider getting them started in the endurance aerobic training. Another big thing that differ in the older population as compared to the younger ones is that when we prescribe the intensity of exercise, in the younger population, we typically do a stress test. We look at their chronotropic response. Sometimes in certain centers, they may do a cardiopulmonary stress test and look at VO2 response. And then we come up with a target training heart rate, a certain range that correlates with a certain intensity of exercise. But in the older patients, we typically don't go with a target training heart rate. We go with a more subjective approach, what we call RPE, ratings of perceived exertion. Now, there are different ways to go about it. But in any case, the reason why we typically do that is because, one, again, generally, in the older population, they have a lower baseline functional capacity. So they're not going to be able to go for very long at all when we do a stress test. And so we're not going to be able to see that big of a difference in terms of their heart rate response. So the heart rate at peak exercise versus at rest. So it's less useful to use the heart rate as a marker of intensity. Also, they have a lot of other limitations, like musculoskeletal limitations, that would limit their ability to exercise. So again, we typically use more of a subjective measure. This is kind of what a general exercise prescription looks like, and we follow the FITT principle. And this is according to the ACSM, so American College of Sports Medicine, which most of us are the guidelines that most of us go by. So FITT essentially stands for frequency, intensity, time, and type. There's also the VP, which is volume and progression. But again, mostly we look at FITT. I won't go into the details of the actual exercise prescription, but again, this is the general recommendation for older adults, realizing that there's a very diverse group, and most of them will not reach these quote unquote minimum requirements, and that the exercise prescription does have to be individualized. But again, the big components include aerobic endurance training, resistance training to improve muscular strength, flexibility, so stretching. Now, in addition to these core elements, particularly in the elderly patients, it is also recommended that we incorporate some neuromotor exercises, especially in those who are at risk of falls or have had falls. Because neuromotor exercises have been shown to reduce the risk of falls. Again, I won't go into details. This is just a list of some examples of what neuromotor exercises include, and other examples include Tai Chi or yoga as well. And so most cardiac rehab programs in Canada has been center-based, and so we would get patients coming into the hospital or coming into the community center, and we do these exercise group-based exercises. And again, it's been shown that these older patients do benefit from that, not just even from the exercises, but also from the social interaction. But what's happening during the pandemic is that because of the need for physical distancing, all these center-based programs have had to be on hold. And so what we've done since the physical distancing restrictions were in place, and a lot of the programs have switched to home-based or virtual programs. And so, you would argue, well, if they're exercising at home by themselves or with family, is it actually as effective, or is it as safe? There's actually been studies looking at this, because even before the pandemic, there was already a lot of interest in terms of how we can deliver cardiac rehab by alternative methods. And home-based cardiac rehab program is one of those that's been looked at. Again, for people to improve access to people who, don't live close to a hospital or live in remote areas. How do we deliver cardiac rehab to those people? And so there have been studies looking at home-based cardiac rehab. Essentially, the bottom line was that based on these studies, that there was actually no significant difference in the outcomes between home-based program versus a center-based program. And in fact, last year, there was a scientific statement that came out from the American Association of Cardiovascular and Pulmonary Rehab, American Heart Association, and the American College of Cardiology. It was a joint statement that came out saying that home-based cardiac rehab is a reasonable alternative to the low to moderate risk patients who cannot attend a traditional cardiac center-based cardiac rehab. What about in older patients? Are there specific studies looking at that? And there have been some. And this is one of the randomized controlled trials looking at those over age 65. Now, this was a small study, only included 75 patients. But they did look specifically at the older population with a mean age of 74. And basically, at the end of the 3-month program, there was no difference in their functional capacity as measured by the 6-minute walk test and the peak oxygen consumption, and when compared between a home-based program and a center-based program. And at 12 months follow-up, so at 9 months after completion of the program, there was a decline in the exercise capacity in both groups. Again, reiterating what we saw in previous studies, that especially in the older patients, we gotta find a way to maintain their exercise regimen. This is another randomized controlled trial, and for the interest of time, I'll direct your attention to the greater than 75-year group. And at the top, which is the total workload capacity, so the functional capacity. the black bars is the center-based rehab program, hash bar is the home-based program, and the white bar is no cardiac rehab. In the center-based cardiac rehab program, what you can see is that between time points of 1 to 2, which is baseline compared to the completion of cardiac rehab, there was an improvement. But at time point 3 and 4, which is 6 months after and 12 months after, there again was a drop. They lost the benefit that they gained during the cardiac rehab program. But when you look at the home-based rehab program, what you're seeing is that there was an improvement, and at least in this study, which included about 700 to 800 patients, that their benefit seems to be sustained. And some of the hypotheses behind why that is the case with the home-based rehab program, why these patients end up sustaining the benefit that they gained, was because when you're doing it from home, it does require more independence. There's less of a reliance on the program staff, and you develop more of a habit, which once you develop a habit, is more sustainable over the long run. So in summary, we know that cardiac rehab is beneficial in patients with heart disease, and certainly in those who are older. Exercise prescription, it has to be individualized because of the significant diversity and differences in this population in terms of their frailty, physical limitations, and comorbidities. And lastly, studies have shown that home-based cardiac rehab is similarly effective to the center-based cardiac rehab, which we're able to utilize during this time of the pandemic. And I'd like to just finish off by leaving you with this feedback from a participant. So it was around March when everything kind of was shut down and we needed physical distancing. And the first group of patients who went through this cardiac rehab program are now finishing. So after a 6-month program. And this was a feedback by one of the participants who was one of the first to start this home-based virtual cardiac rehab and is now finishing. And that concludes my part of the presentation.
Thank you both very much for the presentation. What you're hearing now is the clapping in the distance. I'm sorry that we're not in the auditorium. I have a question for Dr. Lau. Those are great general principles for how to exercise and how to give advice to someone who's elderly. Are elderly patients given an assessment and given these prescriptions? So is in terms of a training, does a trainer or someone equivalent to a trainer see them to give them individualized instructions? Because I can see not knowing what to do or how to do it. And the second part is there any lack of confidence amongst some of the groups? Because part of in-center cardiac rehab has been the safety of having potentially an untoward event while doing exercise. So maybe you could respond to those?
Yeah, those are very good questions. So in terms of addressing the first one, so the initial assessment they come in is they have an intake assessment with one of the cardiac rehab cardiologists, and then we define what's the risk level and so on, and then they come in for an in-person visit with the clinical exercise physiologist for 1 or maybe 2 classes of in-person where they get education, and then the clinical exercise physiologist can kind of have a look at what they can do and whether there's any physical limitations and so on before kind of recommending what they can do at home. Now, there are, especially in the geriatric population, there are suggestions that we should have a more comprehensive assessment, geriatric assessment, in terms of frailty and so on, which, admittedly, that most cardiac rehab programs have not incorporated. But it is something that we may need to consider in the future, again, as more and more of our patients are going to be in this older age group, over 75 and whatnot. In terms of the second question about, what was it again? It is, sorry,
confidence these exercises in an inpatient or in
Oh, right. Yes, got it. Yeah, so their comfort level and so on. Yeah, so there are definitely patients who don't feel as comfortable, exercising at home by themselves and so on. And so they choose not to involve with the, in these virtual classes. But what we've been doing as well is that for these individuals is that we provided ongoing telehealth, telephone visits where the staff, the exercise physiologists continue to touch base with them, at least provide them with some recommendations on a day-to-day basis of what they can do, like going for walks and how long and so on, so that they can still continue to at least be somewhat physically active during this time. Now, in terms of the higher risk patients, this is kind of uncharted territory because all the studies that were done before were done in the low to moderate risk patients. And that's the recommendation scientific statement by the ACCHA. But what we've had to do is that, it is these even the high risk patients who would benefit. And this is kind of a little bit of an uncharted territory that we have to deal with during the pandemic. And I think as we move forward, we're going to have more information about these specific group of patients and how they do.
Thanks. Are there any other comments or questions from the people that are viewing this presentation?
Hi, it's Martha Spencer here. Denny, I was just wondering, a lot of my patients obviously have cognitive impairment, and I can see that as a bit of a barrier to doing the exercises, and also especially now with telehealth. And I'm just wondering kind of what you guys look at in terms of cognitive kind of cutoffs or cognitive capacity to be able to carry through with this. And my second question is, I think we were talking about HEF-REF, but what is the evidence like for HEF-PEF, which is obviously so common in our population?
Yeah. So again, with the first one, we kind of similar to what I said before is that, there are recommendations that, especially for these older patients, that we should incorporate some of these kind of multi-domain assessment, cognitive frailty and so on, which we have not actually been incorporating during our initial assessment in our programs. And kind of what we've been doing is, and again, it is something maybe what we need to look at in the future, but what we've been doing is, we get them started, and then if the exercise physiologists and the nursing staff, when they're in touch with these patients, realize, oh, okay, they haven't been able to follow the instructions, they haven't been able to, join in on these classes, then we'll be notified and we'll say, okay, maybe they're not the best candidate for our current program. As for the HEF-PEF, there has been studies done at that, but again, much smaller numbers than HEF-REF. And all the studies in HEF-PEF did not look at the quote-unquote hard outcomes, mortality and so on. But what they've generally shown is an improvement in their functional capacity, so improvement in their peak VO2 and 6-minute walk test. And then also some evidence in terms of reducing hospitalization.
Any other questions? If not, I'd like to thank our speakers today who were excellent and gave us insight both medically and physically, and emotional and distant learning support. Next week's Grand Rounds are going to be brought to us by the Division of Respirology, and it's entitled New Frontiers in COPD Research and Care. And as predicted, it'll be Dr. Don Sin who's presenting. So thank you to our speakers, and thank you for everyone who's participated today.
Thank you.
Thanks for coming.